I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign. There are 3
parties in conference, including you.
Quite a few of you are rolling on new facilities and that you need their location export Excel workbook for your mapping. So just make sure now you can tell your facilities that they can export the locations and send it along to you. Also wanted to let you know direct CDA automation is up and running. Be really interested in letting us know if you're using this method of CDA import. Also, please send us an email if you need more details, more information, or just help along with this new process. We just rolled it out. We still get this question quite often, so just want you to update your help desk. The user rights to import CDAs. You have to have administrator and all rights allows users to import all CDA types, which would be like your BSI, UTI, and so on. For antimicrobial use and resistance, the user rights restricted user to AUR CDA import only. This is primarily used for like pharmacists and so on that are only interested in the antimicrobial use and resistance. So just give your help desk a heads up so they can help your facilities better correct their rights for the users. Some more general updates. This is referring to our implementation guide information and the HL7 rules. Beginning with the R1 normative IG, NHSN can no longer distribute the implementation guides for the NHSN HAIs. You'll need to obtain the IGs from the HL7 website. HL7 members will be able to access the IG when it's published. Non-HL7 members will be able to access the IG starting 3 months after the initial publication of the IG. Non-HL7 members will have to register, which is not to be confused with joining with HL7 to gain access to the IGs or any other HL7 standard. And we will continue to distribute the NHSN supplemental documents. Now we'll discuss NHSN Release 8.2. It's presently scheduled for July the 26th, 2014. If that changes as we get closer to that date, we'll just give you, we'll let you know. A high-level list of changes are we have an addition of CDAs for antimicrobial resistance, and the dialysis module is moving to a separate component. So for antimicrobial resistance overview, it's referred to as AR or ARO. You'll see that especially in our supplemental documents. It's a part 2 of the surveillance for antimicrobial use and antimicrobial resistance options. The overall description is antimicrobial resistance will provide an evaluation of antimicrobial resistance data within healthcare facilities using a standardized approach and will facilitate future regional and national assessments of antimicrobial resistance. It is CDA import only, so there's no manual entry, no user interface screen. It includes 2 CDA types. There's a numerator and a denominator. Any facility with the patient safety component activated is eligible to import antimicrobial resistance. Facility is not required to submit AU, which is the antimicrobial use data, if they submit AR data and vice versa. They're both very separate. Event is not required for CMS reporting or for dialysis type reporting. And there's a link to the AR protocol on the NHSN website is provided right here. The title, since you're going to have to go get the implementation guide from the HLSN website. I've listed the title and also the zip file name for download. So it's CDA R2 IG HAI Report R1 2003 August. We will refer to it as the R1 norm, and there's the HLSN website right there. Make sure you use the Lantana CDA validator. As always, each time they create an IG, they add the item to the list of validations. So you want to make sure you select the IG release number for which the CDA is based upon. So for the AR, you would check the one selected there in green, which is the normative R1. If you were still doing your R9s, you would select the one above it, the DSTU R9, and so on. So make sure you select the correct one. For now we're going to discuss the numerator. You can compare it to your CDA impact notes, CR535. It's a single patient record per organism. The locations are defined in the IDM, and it requires reports to cover all NHSN-defined inpatient locations and select outpatient acute care settings. This is the same as used for the AU. So make sure you refer to the IDM locations tab. The eligible organisms are listed in the protocol in IDM, and also the eligible specimens are also listed in the protocol in IDM. They include the spinal fluid blood, lower respiratory, and there's a defined list of acceptable respiratory specimens, and also urine. There's defined antimicrobial panels per organism and specimen, and we'll review that. I'll show you some screenshots on the protocol in the IDM. And also a few business rules, 14-day business rule for spinal fluid and blood specimens, and a 1 per month business rule for urine and lower respiratory specimens. I have this screenshot. This is actually in the protocol, but it gives a good view of the fields that are included in your CDA or that you're reporting. Most of these look very familiar to you. ID, patient ID, birth, gender, date admitted to facility, specimen collection date, which, like the lab ID, this is equals your event date, location. This does include the isolate identifier, which is what the isolate identifier for the laboratory, and then the organism. This is a screenshot of, I tried to group it together per color just so you know how it's grouped together. So, for example, if it's a Staph aureus, it will require the 2 tests for agglutination and the PCR, and then you would have your antimicrobial defined, and then the 3 tests for E-test, MIC, zone value, and then the final interpretation of the 3 would be your final interpretation result. This is a rendered narrative section example from your CDA, also showing how it's divided up, just to give you another high-level view. This does not include the header information, so your findings would be your blood specimen, specimen collected date, procedure date, your location, and then your organism, which is Staph aureus, your result for your agglutination and PCR, and then your next group, starting with the blue line, with the example you would have clindamycin, and then your result for your E-test, Kirby-Bauer, MIC, and then your final interpretation result. Of course, you're probably not going to have, most labs wouldn't redo every type of method for every drug, so you can report not applicable. And then the next one below for vancomycin shows an example of the E-test is susceptible, the Kirby-Bauer is intermediate, and the MIC is susceptible, and your final interpretation would be the most resistant value, so you would report an intermediate. This is a screenshot of the IDM. You'll see column L, where the arrows are, has been added for the ARO pathogens. So there's your list of the valid pathogens you can report for AR. There's another screenshot. We have added a specimen source tab to the IDM to include all the specimens and differentiate the lower respiratory from the other ones that are not valid to be reported. So, and also it shows the lab ID specimen source. That's actually never been added. You did have it in your IG, HAI vocab, but now it's been added back to the IDM. This is a screenshot showing the drug panels that we're using. We've defined it by anti-P20, anti-P21, anti-P22, and so on. So depending on which organism you report, you would need to use the valid or the correct anti-panel for that organism. Next, we'll talk about CR843, is the antimicrobial resistance denominator, or the summary report. One denominator is reported per month, and it's always for fact-wide N. It's really simple. It just includes patient days and admission count. Just as an FYI, the IG does contain requirement for blood cultures performed. It was removed from the protocol. However, it will still be required in the CDA, so you can use dummy data, and it will not be stored to the database. But due to the schema and so on, validation, HL7 validation, it still needs to be included. Other antimicrobial resistant additions to the user interface that you will need to know about. You will need to add the AR to the monthly plan. It's being added right there under the antimicrobial use and resistance module, so you would just check the box if you want to do antimicrobial resistance. Confer rights. If you want the user to only have rights to import antimicrobial resistance, you would select the boxes shown there. There will be the capability to delete an AR event. So this is a screenshot. You would go into Find AR Event Type. You would select the location, the AR antimicrobial resistance, and then it would bring you to the next screen, and you would select the AR events to delete. This is as far as you can go. Usually you can click on the event ID and open up that event, but there is no screen, user interface screen, so this is as far as you can go, but you'll be able to delete any events you wish. You'll also be able to delete the AR summary report. It's very similar to the AU deletion. From the blue taskbar, you would select Delete AUR Data, and it brings you into the next screen. You would select the summary data type would be AR, and the location code would always be FACWIDE-M, and you would be able to delete the summary report that way. These are good to know, but no CDA impact. The dialysis module is moving out of the patient safety component and will be a separate component. All dialysis test facilities and real facilities will automatically be switched over to the new dialysis component when 8.2 goes live. Has no effect on the dialysis CDA whatsoever. Here's a screenshot. When you log in, you would select dialysis, and then you would see your facilities pop up in the next that you have access to. CMS requirement update, just want you to be aware so you can help out the facilities that you're helping report. Beginning July 2014, CMS will require the Medicare beneficiary number to be reported for all Medicare patients. It includes CSI, UTI, SSI, and Lab ID for MRSA and C. difficile. So you can add that Medicare beneficiary number to your patient information in the R5, UTI, and Lab ID. You do it the same way as you would do your R9. The field remains optional for NHSN, so no validation will occur, so it will be up to you to add it. So we're happy to provide more information on the new antimicrobial resistant CDA import. As always, we offer one-on-one meetings, and we'll include the SMEs. And actually, the SMEs, one of the SMEs is Amy. If you did AU, you're very familiar with her, so she is also one of the SMEs for the AR. Make sure you use the R1 norm IG. The supplemental documents you want to make sure you refer to are the draft AR IDM for vendors and the CD impact notes for release 8.2 and 8.3. And delivered later, we're going to put together a helpful hints document. My sample CDAs I've created per antibiogram panel. I have not, we're not that far ahead of you on our development. So as soon as I've tested them and made any corrections needed, I'll be glad to share those with you. And then also the final version of the 8.2 IDM when it's completed.
Okay, so next we're going to talk about NHSN Release 8.3. And this is the early 2015 release. It's currently scheduled for January. As you know from working with us the past few years, we put most of our surveillance protocol changes in the January release so we can analyze our data from for complete calendar years, knowing what changes kicked in at the beginning of each year. An important thing to note about the January 2015 release is that hopefully by then we'll have our CDA pre-production vendor test sites available. Those are under development right now. Each individual vendor company will have a test instance of NHSN's development version. So like Mindy just said, you know, we don't develop that much farther ahead of you, but the vision here would be that before we go live in January, you'd be able to test that January version in let's say, you know, November to get you a head start so you don't have to wait for us to go live before you can do your testing. We'll do additional webinars about that as the year moves on. In the January 2015 release, we are touching a fair number of CDA reports. The summary reports for ICU, SCI, and NICU are going to be updated. There are additional protocol changes for SSI and procedure. UTI is still on the R5. We'll be bringing that up to a new version with some protocol changes. And there are also some minor additions to the dialysis CDA. And we'll also touch on a few other changes not involving the IGs, validation of SSI procedure linkages, moving from ICD-9 to ICD-10 and CPT, and an update to the hip and knee replacement procedure sections. So again, we'll be running off a different IG than the antimicrobial resistance one that Mindy just referred to. This is actually the release 1.1 IG, which we just finished the validating process for in March. Actually, it wasn't validated this winter. We were able to do a minor dot update, and that's how we ended up with the name. In the zip file you see there, the HEI reports R2 DSTU R1.1 with a minor dot update there. So when we talk about the R2 D1.1, we're talking about this IG that will be used to turn on the updated reports in January 2015 and release 8.3. Again, you see the HL7 website link there, and you can go in and download the IG now if you're an HL7 member, and it will be available in a few months if you're not a member. Again, you'll want to use the CDA validator as part of your testing, and it will be updated to add the R2D1.1 shortly. So we'll walk through the changes to each of the CDAs in this part of the webinar. None of them are particularly extensive, but they do require changes. Starting with SSI, these changes will be implemented for SSI events with procedures for SSI events that are linked to procedures done after January 1st, 2015. So remember, for SSI, both the SSI and the procedure are driven by the procedure date, not the event date. So for SSIs linked to procedures done after January 1st, 2015, there will be a new question about whether or not the SSI was present at the time of surgery. And this is at an effort to make the SSIs more appropriate and related to the surgical procedure. If the patient had an infection at the time of the surgery, we'll let the IP note that in the SSI record to say that there's something going on with this patient before the procedure was done. You see in red there was initially going to be an additional question about whether an SSI was identified using a code-based surveillance toolkit, and that actually has been removed from the protocol as well. It won't be in the user interface, but again, because of the schema and the validation, you'll need to have an answer to the surveillance toolkit question in your updated R1.1 CDAs, but that data won't be written to the database. There will also be an additional minor business rule change for SSI, adding along as a specific event time to a specific event type to ventricular shunt procedures. There's also an additional question on the procedure form for procedures that are done after January 1st, 2015. This question is actually only applicable to hip replacement and knee replacement surgeries, but because we can't turn on different versions of the IG for different procedure types, you'll need to move all of your procedures to the the R2D1.1. It is looking at surgical procedures that were done as revision arthroplasties because of infection at the index joint. So is the patient having another hip and knee replacement done because the last one ended up infected? And you can see that that is a yes or no question. I mentioned the summary reports. These are reports we haven't touched in a long time, so we're actually trying to bring those up to the current version of the user interface. For the ICU Other and SCA summary reports, we'll turn these on for January 15 and later, and there will be a new variable added to these CDAs for the number of patients who are on APRV, which is a particular type of ventilation. This relates to our ventilator-associated event surveillance. Keep in mind that we don't have the VAE event numerator available for CDA yet. We're still working through changes to that protocol. We're holding off on implementing CDA for the VAE numerator, but for facilities who are reporting VAE, keep in mind they can already put their number of ventilator days on their summary data form via CDA, and now they'll be able to include this APRV day count on that summary form as well. For the NICU summary reports, again, we'll also be turning this on starting with January 2015, and it's a code change here that you can see the number of central line days is actually being updated to the number of central line days, including the umbilical catheter. That is how people should be capturing the data right now, and we'll just allow that code to be changed to catch up. For the dialysis numerator, again, there will be some updates, and the R2D1.1 will be required for events that occur after January 1st, 2015. And there are two new questions. There is a new outcome with loss of vascular access, and there's also a new criteria of diagnosis, urinary tract infection. And finally, in terms of IG changes, we have a fairly big overhaul to the UTI protocol. That's going to happen for January 2015. Because of these protocol changes, we will be turning on this new version of the CDA for UTIs with event date after January 1st, 2015. Keep in mind that this is one of the CDAs that hasn't been updated to allow for the import of optional fields, such as patient name and race. We will allow the import of optional fields with this new CDA. There will also be 3 new specific criteria you can see on the screen. Those are going to go into the CDAs now and will provide information about how they can be used to call infections in the 8.3 IDM when it's distributed closer to the release. You can also see that the microorganisms on gram stain of unspun urine is going to be deprecated. That criteria will no longer be used. So here's a recap of what will be allowed starting in 2015. So for SSIs and procedures, you guys have either migrated or are in the process of migrating to the R9 CDA for 2014 procedures, and you'll need to do the same thing for 2015 procedures, migrating to the R2 D1.1. Again, for the summary reports for ICU and other, you can still use the R2s or R5s if the summary month is less than 2015, but starting with 2015, you'll need to move all the summary reports that you see on the screen, ICU, Other, SCOT, and NICU, to the new R2D1.1. For dialysis, you should be currently using the R9 for 2014 dialysis data. That will need to be bumped to the R2D1.1 for 2015 dialysis data. And for UTI, currently you're still on the R5, and with 2015 data moving forward, you'll jump to the R2D1.1 as well. I will say that there is some light at the end of the tunnel. We're trying to reset all of our data tracking, our analysis for 2015. So we're trying to get all these protocol changes in before the start of 2015 to make sure that we can use the 2015 data we get as a stable baseline moving forward. We can compare back to the 2015 data, and hopefully the protocols will remain pretty stable. In future years, we've heard that there's a minor change to dialysis coming for 2016, a minor change to CLIP coming for 2016 as well, possible minor changes to Lab ID event, but hopefully the days of having to import 5 or 6 CDAs at once are coming to an end very soon. So non-IG impacts. As you know, every SSI that comes into NHSN has to be linked to a surgical procedure, and we're going to get the manual linkage in the user interface, the linkage between procedures that were imported via CSV and an event, and procedures that are imported via CDA and an event, all at the same standard, because they do all work slightly differently in terms of linking the SSI and the procedure. So you can see in the second bullet there the fields that are going to be required now for that linkage: org ID, procedure date, procedure code, date of birth, gender, patient ID, and outpatient. Keep in mind, if you're reporting data via direct CDA automation, you also need to include the procedure ID in your CDAs. That's only optional for manual import. And we're going to improve the validation by increasing the checks and actually using the outpatient field for CDA, which we don't do now, and requiring that the patient ID between the procedure and the SSI match as well. So that's really important that you pay attention to leading zeros in your patient IDs. If you use leading zeros in your procedure record, you'll need to use them in your SSI record as well. We are still working on our transition to ICD-10 and CPT. Again, this program is going to kick in, in late 2014, and we will begin accepting ICD-10 codes based on a mapping that we're working on in Release 8.3. Hopefully that mapping will be done in July, and as soon as we'll get it, we'll share it with the users and the vendors. They remain as optional fields. They aren't required to be reported at this point. They're required to report the NHSN procedure code, but they can report the ICD-10 or CPT code, and you can see how the CDA does that in the screenshot at the bottom of the page here. After we do that mapping, we think that we'll be able to remove some of the fields for hip replacement, knee replacement surgeries, HPRO and KPRO. Some of the different category types about the type of HPRO or KPRO may be removed. That'll be updated as part of the IDM, and we'll give you a heads up when we know exactly how that's going to shake out. Okay, so just to review, again, these 2015 changes that will turn on in Release 8.3 in January 2015 are in the R2D1.1 IG. We've sent out before this webinar the supplemental documents, including the CDA impact notes, a summary of the changes, and we'll send along the IDM when it's completed later this year. Again, hopefully before Release 8.3, we'll have the pre-production vendor test site that you can use to get a little bit ahead of the game compared to what you've been able to do in the past, and we'll do a webinar about that later this year. And we'll continue to keep you updated as the year moves along. This is only the end of March, and we have 8 or 9 months of time to update you about anything that changes with this release. Okay, and I alluded to this briefly, but future CDAs. Right now we're about to go to ballot with CDA specifications for ambulatory surgery centers. NHSN is working on developing an outpatient procedure component, which is exclusively reserved for ambulatory surgical centers and hospital outpatient procedures. These will have a numerator and a denominator, and we will provide more information after those go through ballot and are available later this fall. I mentioned the January 2016 changes, minor changes for clip and dialysis, and again, possibly lab ID event. We'll keep you posted on that. And again, there's no immediate plans for CDA for VAE and biovigilance until some of the protocols settle down as more and more people start reporting those events manually. I did want to mention the APIC annual conference. Many of you participated in our large vendor meeting before last year's APIC conference and individual vendor one-on-ones. We'll be doing the same thing this year. We will distribute via email a save the date for a CDA vendor meeting on Friday, June 6th in Anaheim from 1:30 to 3:30. That will be followed up by the NHSN IP update. That information will be distributed to all NHSN users, but as a vendor, you're welcome to attend that meeting as well, space depending. During the conference, we're glad to meet up for one-on-one meetings. And again, we'd ask you to reach out to us to schedule that. Those will be Saturday morning from 8 to 12:30, and I think based on our experience last year, we'll stretch those into Sunday morning as well. We should have no problem getting a room for those. We'd ask you to contact us if you'd like to do that. And then we're also doing a CDA for IPs session during the conference, which will be good. Also about APIC, in case you're a new vendor who's not aware of this, APIC does keep a list of vendors who tell them they're able to make CDAs to send to NHSN, and that's a PDF that they keep posted on their website. You see a screenshot there on the right side of the screen. The link is a little blocked there, but in the version of the slides that we sent out, you should be able to link to that on their surveillance resources website. And you see that if your company is not listed on this and you'd like to be added, you can contact Tom Weaver at APIC using that contact information. Again, we'll send out the IDMs when they're done. We're glad to take feedback at nhsncda@cdc.gov. We're glad to work with you as closely as we can and offer individual vendor webinars. And that will actually end today's webinar. Thanks for joining.